most people would know the A&E as accident and emergency, but for us, emergency physician, it carries a vastly different meaning, right, Shahrul?
Yeah, most of the days it can be anything and everything.
Hi everyone and welcome back to another episode of KoPiJom. We're both consultant emergency physicians from KPJ Berhad. My name is Aliyah Zambri. I am the consultant EP in KPJ Klang Specialist Hospital.
And I'm Dr. Shahrul Nizam bin Ahmad Zamzali, emergency consultant in Ampang Puteri Specialist Hospital.
Excellent. So today we're here to kind of share our insights and experiences in the A&E. Some stories, some experiences. And what we're hoping to get is to get real talk of what A&E is like. Stories that actually stay with us.
Yeah.
So without further ado, let's get started. Just tell me a bit more about yourself and how you end up where you are at the moment.
Okay, so again, I'm working in Ampang Puteri Specialist Hospital as an emergency physician. So basically, we help out the emergency department. We manage the emergency department. We manage emergency cases, and as a lot of people knows, emergency department is where this is the first port of call when a patient comes in. So patient comes in through emergency department. Sometimes they are stable, sometimes they are unstable. So it's our job to see this kind of patients.
Right.
So how is it
for me?
Yeah.
Pretty much the same. I guess you can say that my role is kind of a two-pronged role where I do a bit of clinical work. Not a bit actually. Chunk of it is clinical work, and another chunk of it is administrative work.
You cannot escape from that.
The title that was given to me was consultant emergency physician and head of A&E services. As head of services, you kind of have to not just see the patients, but of course manage the entirety of the staffs there, from care assistants, from guards, even care assistants, from medical officers, and also
nurses.
The nursing.
So
kind of have my tendrils everywhere to make sure that the services run.
And also because even though that we are emergency physicians, a part of our scope would be in the hospital, running of the emergency response plan, disasters, and what is the code blue code.
Can you perhaps explain to our audience what code blue means?
Code blue is when we have two types. We have one code blue, which is a patient that needs a resuscitation, meaning a patient that is not breathing. So usually in a code blue, we are expecting to do CPR, cardiopulmonary resuscitation, chest compression, and all that.
And airway.
Another one, we have RRT, Rapid Response Team. Rapid Response Team is when a patient is not really sick, but going to get sick.
Deteriorate.
We anticipate that this patient is going to deteriorate. So in this kind of patient, we also have to respond. So while you are seeing patients in the emergency department, we are always on the alert. We are listening if there's any code blue, to the alarm, to the
PA
codes.
system. They always say that if you are an emergency physician, you have this specific type of personality.
A bit
superbly deficient in attention span.
Short attention span.
Excellent. Very good.
A bit crazy.
Well, speak for yourself.
It's not me. Someone else. Because you are seeing cases that's a wide range of cases. So sometimes you just can't focus.
Too much on it, and then you just like, okay, I've done whatever I need to do. Just hand it over to the next guy. So there's also another saying that I have a lot of sayings that emergency medicine is kind of like the most critical first 15 minutes of any specialty.
Exactly.
Another point of view is like they were saying how we're like jack of all trades, master of none. But I would like to differ and argue that maybe having a bit of knowledge about everything and managing the cases before giving it to the actual experts, I think people still need that role.
And then I feel it helps to have the first encounter, to make it matters, to give the correct first treatment. Because sometimes it takes a while for the patients to be sent up to the wards or to the OT. So that would be the life-saving treatment that's started in emergency. So resuscitation and starting antibiotics, part of the sepsis protocols and all that.
You're right. And like when patient comes in very unstable, and they don't have a specific complaint, they just come in
Exactly.
unwell.
Yeah.
So then it is up to us,
To
emergency doctors, and then of course us emergency physicians as the next layer,
Yeah.
to ensure that the patients are treated correctly and being sent to the right specialty. Kind of package the patient nicely, and then send it over to the next expert care.
Definitive care.
Yeah.
And also because for us, we do not have the luxury of differentiating patients.
Yeah.
The patients that walks through the door is undifferentiated. We never know what's wrong.
Yeah.
Patient might come in with shortness of breath.
But it could be anything.
It can be anything.
Yeah, exactly.
Yeah.
Katakan, someone has developed a cardiac arrest in front of you, and the time is ticking. Every second counts. You know, we know that every minute that passes by, chances of survival reduces by 10%. So after 10 minutes, 100% gone.
Yeah.
So how do you kind of, knowing that kind of facts, the the amount of pressure that we have to perform in order to ensure that the patient's survival is there? Like, how do you keep up with that kind of demand all the time, 24 hours a day when you need it?
That's where the teamwork comes back, comes
Yeah.
into play, because it's not just me, because I
Yeah.
have to move the whole team. So let's say if we are taking for time, let's say if we have a cardiac arrest, we need to move. So I'm just going to, I think of my role more like a conductor in an orchestra.
Ooh,
rather than
nice
that-
analogy.
yeah,
Go on,
rather
how
than-
long did you think of that?
rather than a person that plays the musical instrument, because we need people to play the instrument, but we need someone to oversee the whole scene. So at now, and with my physical, because you're feeling tired, you cannot be resuscitating
No.
physically the clinical.
In your defense, CPR is hard, okay?
Yes, and it's a good
tough.
workout. It is good workout, but
After 40, it's gonna wrap your back.
Yeah, and that's why we need to always think of your staffs. Are
Yeah.
you okay? Are you tired? Do you want to swap?
Yeah.
So for me, the teamwork, and also trying to orchestrate everything so that everyone functions as a member of the team.
Yeah, and I think you're associate professor, the esteemed associate professor, Dr. Shahrul, from a academic background. Myself as well, I was a lecturer prior joining KPJ, lecturer / emergency physician.
Yeah.
So there's a lot of kind of training and
Exactly.
teaching and simulation trained. That comes into making sure that orchestra that you're trying to conduct goes smoothly, and that everybody knows their role, and you're just there to make sure that things are going well.
Yeah.
So I think managing pressure when the stakes are high, when people are literally dying before your eyes, is actually comes from a place where you're well trained, you are calm, collected, experienced, and you've managed this kind of cases before, and good communication, close loop communication, and ensuring that your team is comfortable enough to communicate with you as well. So that's where good leadership that comes in. Like if they respect you from their previous occurrence with you and their experiences with you, that's where they're going to resuscitate the patient with you, because it's not you doing it alone, as you said before. So that's a great point.
And also in terms of training, usually it was said that in a time of stress, you fall back to your level of training.
That's right.
Because then it becomes muscle memory.
Yes.
You just act.
It's a reflex.
It's a reflex kind of thing. So that's where I tend to do a lot of simulations.
That's
I
good.
try to make drills in the department itself. So let's say a patient comes in, what do you do? Okay, we call everybody. Okay, come on, and then putting in some pressure. Okay, come on, quickly.
Yes.
So just to put some pressure to them. So
when the actual case comes,
they are better
prepared.
equipped. Yeah,
And
with
they're
the pressure.
prepared.
Yeah. So really sorry again for the team.
I know, I'm sure they appreciate this kind of leadership
yeah.
where training and education is being put forth as very important.
Mm-hmm.
What is kind of the most unforgettable case or patient experiences? We're not going to be very specific to protect the patient's confidentiality, but what is this one patient or this one case that keeps circling back in your mind that you still share about until today?
There is a few, but just to share about one, we've got a patient who's well but complaining of chest pain. Went to the clinic, and then the clinic saw from the ECG, the heart reading, that there's a heart attack. So the patient we're just complaining of a
Mild
bit of
chest pain.
discomfort.
Yeah, okay.
I'm well. The GP sent me here. So when we saw the ECG, it's a heart attack MI.
Yeah.
So we brought him to the resuscitation, and then at that time we wanted to give some thrombolytics. Thrombolytics is a clot buster to block to dissolve the clot that in the heart, in the coronaries. There are side effects of that. Suddenly the patient developed abnormal heart rhythms during that, and then ultimately after 3-4 hours the patient passed away in the emergency department.
Why was that memorable to you? I mean, obviously,
because
apart from
the patient walks
outcome.
in thinking that it is I don't feel sick. I was sent here by my GP. There's a child, there's a baby, he's about 3-4 years old, who did not understand what's going on.
Oh, I mean the patient's
With the
child.
patient, so the patient comes in with the baby, with the wife and the daughter. The daughter did not understand, and this was about 1 week before Raya.
Okay.
So imagine that, because a patient who's well coming in and having to deliver the bad news to the family.
Yeah.
So that's what's memorable to me. One of the memorable cases.
Yeah, it's very sad.
Yeah.
Now, a heart attack is obviously a very high mortality kind of a case, and we can only try our best to a certain level. And every medications that we give comes with a little bit of risk, but also, you know, if the benefits far outweighs the risk, we will proceed with that. Of course, with support from our cardiologist colleagues and things like that. But sometimes these kind of outcomes are inevitable. So how did you deal with that patient's passing?
That is a thing, because usually in emergency, because not only because back in my time, before coming to the hospital to Ampang Puteri, I'm always involved in disaster management. So again, we see bodies being pulled out and all that. I believe that how to cope with the death would be, we need to have a closure with the team. Okay. Because sometimes we don't know whoever in the team, they might be affected. Because sometimes when we are resuscitating, let's say we are resuscitating a baby, some of the staffs in the team might feel that what if this is my baby? And let's say if you are resuscitating an elderly, some of them might just lost their parents. So what I do is always I try to have, after a very traumatic
debrief.
But not for all cases. But if you feel that this is a traumatic cases, you feel that there's what do you call it's like
room for improvement,
and also when you feel that there is a mental or emotional burden with that resuscitation, especially kids, especially pediatric patients, I tend to do a debrief with everybody in the team, so just to see that everything is okay, and then try to monitor them.
I think it's
how about you?
For me, that's an important point, because when we go into resuscitate our patients, the end in our mind is always the patient survives and the patient gets better and gets sent off to ICU when we resuscitate anyone, children, elderly, adults. But when it does not go our way despite our best efforts, that is when things are tough to accept. So you're right in the sense that debrief is also important for us to kind of get like insights from each of the team members who are involved in the resuscitation. But being the one who has to break the bad news is... I can't even describe to you. It's the worst thing to feel, because you have to tell them like, I've done my absolute best. The patient's family who survived. So the I've done my best, but the best outcome, the one that we wanted, did not happen. The patient did not make it, and there's like we go for trainings, kan?
For breaking bad news.
For breaking bad news. For exams, we have in master's level, because you have to do it right. The patient's family, katakan the patient did not make it. The patient's family carry that emotion for the rest of their lives. So that's a very important exchange.
And then during that time, it's very important for me. It's very important for you to maintain professionalism. You want to deliver all the information, you want to comfort the patient, but you don't want to give them false hope. Let's say, okay, we are doing the resuscitation, we are doing the CPR.
Whilst the ongoing resuscitation?
But, let's say...
There is a small...
Yeah, but
small
we
chance.
never know.
Yeah, there's a small chance the patient might not make
these are the
it.
things.
To managing expectations of the
so,
family members. So emotionally, I don't cope well. I have to say with patient's death. It's always the smallest coffins, smallest bodies that felt the heaviest for me. So the most memorable case is a child that was brought in around my own child's age. Came in CPR from the Klinik Kesihatan, came into our A&E. This was from my previous hospital. Now the child was down with no pulse for a long time before CPR was initiated. And I'm going to talk about why it's important to learn CPR. So the child did not survive. We tried for an hour. Everyone was called. I felt like the only person who did not come in for that resuscitation was probably the janitors, because I literally called everyone, like, let's help this kid. But the child did not make it. I could hear the mother wailing outside. Like, wailing, crying, and I cried. I know we shouldn't be emotionally attached. I cried because it feels like that could have been my child.
Yeah, because basically, even as a doctors, we are humans after all. We are your mother, we are fathers, we are parents. We cannot detach that. You cannot detach that.
We
try, but
sometimes unsuccessfully.
So that's why sometimes it's good to take a time off. When you feel it's too much, take a time off. And then people should understand that I need this time off for myself.
Do you watch Scrubs?
Yeah.
Okay, so there was a line by one of the guys and saying, why do they were making jokes about things, and they're like, you know why they make jokes and make light of things like that? It's because they need to shrug it off and then go to the next patient, because you need to move on. Like for me, after that resuscitation, I had classes with master students. I had to teach them and give them lecture. So I had to wipe my tears, go to the toilet, make myself look presentable, and then give a lecture. Whereas, but at the back of your mind that mother has to live with the reality that the child is gone for the rest of their lives. But if we keep that, we're not going to be able to move on. We're not going to be able to function.
Because we have a responsibility to the next patient.
That's right. That's right.
Okay. Okay. Talking about that, you mentioned about CPR. Let's say, why do you think people? What are the symptoms that people tend to ignore when they come before they come into emergency? For in your case, what do you think? This is not a academic question without the percentage and anything. What do you think?
What kind of symptoms that people tend to ignore before they come in and they take it for granted, but it's actually something very serious? Okay, I would say abdominal pain.
Okay.
Fever. Chest pain, usually they come in. Chest pain patients will be, I've got chest pain, I'm going to check regardless. But I think there's enough awareness with regards to chest pain. Breathlessness on effort, meaning that I climb up a stairs and I'm feeling a bit breathless. It's okay, I'll just climb up 5 more stairs. But oftentimes these are the patients that have actually really bad conditions that could lead to deterioration. Fevers are pretty, if you ignore fevers, and then you're not drinking and you're eating and you're lethargic, the patient comes in oftentimes pretty bad. Dehydrating, especially for kids. Don't leave your kids with fever for 4 days at home. Bring them in. Never leave your kids with fevers more than 3 days, more than 2 days. Low threshold to take them into our A&Es. Because I have seen one too many times having to resuscitate kids.
Because for public, just to share on it, kids are not mini adults. Because when they deteriorate, they'll deteriorate faster. Okay, so they have the capacity to withstand fluid loss, but kids do not. So again, if your child is unwell, bring them in.
Bring them in and let it get checked.
For me, in terms of that, it will be chest pain, because I still feel that people, yes, they are afraid of chest pain, but they do not come in immediately. They would say, chest pain, I'll just put in some ointments or something, or I think this is something I ate, this is gastric, and then come in 3 hours later.
Right.
So yes, they recognize it's chest pain, but they
might not have the awareness.
tend to
Shrug
not to come in earlier. For me, another thing would be for public is to know when to go where.
When to go where?
When to go where means that if you have a fever, do you know which kind of fever that you can treat at home, which kind of fever that you need to bring to the clinic, or which kind of fever that you need to bring to the hospital. So you need to know, because sometimes simple fever you can manage at home. Simple fevers requiring antibiotics, you need to go to clinic. Simple fevers that needs IV fluids, IV antibiotics will need to be seen at the hospital.
Yeah.
So the knowledge of when to go where is quite important, because I remember there's one case, I think in the same hospital that we worked before, a child fell down and bled. In that case, bled a lot from the femoral artery, the big artery there. So the child was brought to a clinic, and then the clinic saw the patient, sent the patient to the hospital.
Okay.
So what happens was, during that time there was a delay in
recognizing,
in bringing the patient to the hospital. So
Alright.
even when the patient comes into the hospital, when we pump in blood, when we pump in fluids, it's a bit late, because we did not bring the patient in earlier.
right?
So we have to recognize that certain cases, you don't waste time to go to the clinic. Go straight to the hospital.
Because when it reaches that tipping point, it's difficult to kind of turn back. But for it to reach the tipping point, there's a good amount of compensation that our body can withstand. But once it reaches after that, then it's difficult for us to reverse, regardless of whatever we do for resuscitation. So just kind of something as simple as, like I did mention about abdominal pain. And the reason behind that is people tend to ignore aches and all that for years, and then they come in and it's actually kind of an advanced
with
stage
tumor,
or something worse than that. So I think it's always good to come in and get it checked. So we both come from academics background. What are some of the research initiatives that you are currently embarking on now?
At the moment, I'm interested in looking on the length of stay in emergency.
Fine, okay.
Length of stay in emergency and how to monitor it. So we are monitoring the length of stay, the onboarding time, because I feel that most of the time patients can be bring up to the ward faster. So
by onboarding, can you just clarify? For
onboarding
our
is let's say a patient comes to emergency department, we need to do some blood tests, we need to do some investigations to find out what's wrong. When we know what's wrong, we refer to the consultants and to the specialties. But at that time, we are waiting for bed. We're waiting for GL, we're waiting for the guarantee letters, we're waiting for the consultants. So these are all factors that influence or makes it longer for a patient staying in emergency. So for me, the longer the patient stays in emergency, there's a few things. One, it denies the patients of a proper care in the ward. Second is it creates a block so that new patients cannot come in. So that bed can be utilized for other patients, but it's stuck. So I'm trying to look into the length of stay in emergency and what are the factors, and then how we're going to reduce it. So it's a practical flow. In terms of education, I try to make myself still do a bit of teaching. Sometimes we have post-basic students coming in from for nursing, mostly from nursing, and then that keeps me talking about talking about the academic stuff rather than the practical stuff. So we do, because we've got KPJU sending students over. So to me, sometimes it's a break, as you say. After seeing patients, after the meetings, I just need someone to share what is the latest guideline. So quite bad. How you distress yourself?
Well, to distress myself, I read journals and publications and share it with my staff.
The staff, and then the staffs have to listen,
whether they like it or not. For me, my research, because I've got a very good research team in my previous hospital, because we came from university. So obviously, we have like a team. We call ourselves the research cartel. So we would publish publications and stuff. So when I left the team to go to a different hospital, like I'm now in KPJ. When I left that particular hospital to come to KPJ, So I don't really have like a research team just yet, but I'm doing kind of my own data collection for. I'm doing length of stay as well, just to kind of improve flow processes in our ED or A&E to make sure that when patient comes in, the process from coming in, getting triage, getting treatment, going up to the ward, everything is smoother, and then the length of stay is reduced. The patients are happy, everyone's happy, management's happy. Okay, so like, and they keep the patient satisfaction, because that's what we want to achieve, to make sure that not just we provide good clinical care, we're also providing good experience for them. So that's one of the research, sure. But another thing that I'll be interested to look at is probably things like how we can probably use AI in our A&E. I did speak to our head of emergency medicine, Dr. Noor, who is currently medical director in DSH1. So so she is so much. She's very interested in doing and integrating AI in flow processes to increase efficiency. Part of it is like triaging with AI and things like that. Things are very in early stages, planning stages. But I think if we work together in different A&Es across KPJ, we can actually get something done effectively.
And also because of the support from the KPJU. Because we have students from KPJU, so that's also with the grants and everything. So it helps.
So what do you have to say for students or aspiring emergency physicians?
For me, you need to know what you're getting into.
And what are you getting into, Dr. Shahrul? What have you gotten yourself into?
For 2 decades plus.
2 decades.
I think you need to love what you're doing, and you need to have your passion there. You need to know that sometimes you are not okay. We talked about difficult patients earlier, but sometimes you have a good experience. We have sometimes a good childbirth. Happy moments. We managed to remove a foreign body from someone's throat, and then they are really happy. So even the small things helps. So you really need to know when you are doing emergency what you're into, because you don't not know today will be the same. Okay, every day is a different thing, and do not it's unexpected.
Okay.
So
for me, emergency medicine is a thankless job.
Yeah,
right?
That
Nobody's going to pat your back and say, good job resuscitating that patient, but everybody's going to bark at you if you missed a step or whatever. I don't think you should come into emergency medicine thinking that people are going to give you honorary and recognition so much. It's a tough job. People can... And I think it's a rather infantile specialty, isn't it? Compared to other specialties. It's only been here, a couple of decades, whereas other specialties have been around for aeons, centuries. So I think we're still trying to galvanize our specialty to make sure that we're improving our training for sure, with really strong academics, really smart academic people who are running the show and making sure that the curriculum is there. But also, we're trying to think outside the box. We have to be coordinators, middlemen between primary teams and the patient. You're your patient's negotiators. You have to have good communication skills. You have to be articulate. You have to. This is what you're getting into. You gotta you gotta package your story, and you're supposedly supposed to know everything about the patient within the first 15-20 minutes when you refer. And I don't mind it. I think it's part of the job. And I kind of love it.
The thankless part, I said to my team, would be, that when patients comes in, they are in stress, they are in pain, they don't know what's going on. So this 15 minutes, 30 minutes, they will not remember your name. No. They will just remember, the doctor in ED or the staff in ED. But when they go up to the ward, they are much more stable, they are well.
Better mental clarity.
And then they tend to notice the name tags. This is the and then they will get compliments, good reviews.
Compliments.
So I said to my team, we are not here to get thanks from them. The thanks is the patient goes up. That should be the thanks.
In a stable, better way that they came in. They're in a better shape as to where they came in. And that's where you come in to make sure, or when we come in to make sure that our staff feels seen,
and then they feel
acknowledged and appreciated. That's where you're like, hey, good job on that resuscitation.
Even if people don't appreciate you, I appreciate you. We appreciate yourself.
Exactly. We recognize your good traits and what you've done, and we appreciate. And I think that's how we move the team forward, and preventing them from feeling burnt out. Okay.
How about do you feel that because being a doctor, I don't know, people always your family and friends calls you up and they say, hey Aliyah, what's wrong? I've got this consults and everything. How does it happen to you?
Jangan terasa. Of course. Oh my goodness.
Medical hotline 24/7.
Medical hotline 24/7. Okay, but yes, I do get, and I don't mind it. I just have to make sure if they watch this that it's okay. Just ask me anything. I prefer for them to ask and get the right kind of treatment rather than like not get the attention that you need. Yeah, so it's okay. But and it's okay.
Yeah, for me pula, I feel yang I cannot, because they are expecting to diagnose over the phone or with the WhatsApp with the picture. I said it's very difficult for me to do that. So what I tend to do is I tend to direct them to go to clinic or to go to which hospital or to which specialty, because sometimes it's very difficult to see. They send a picture. What's this? I said, I don't know. Maybe a filter. I don't know. So
look, I would give them a bit of advice, like okay, just give this meds. If it doesn't get better, then come on in. But my house is completely equipped with so many medications.
Mini pharmacy.
It's a mini pharmacy. I've got like a complete first aid kit, and that if one of the neighborhood kids scrape their knees, I've got you. I've got all the stuff I need right here. Trying to wear that hat also at the neighborhood, because we're kind of a close knit.
Because I tend to believe that being a doctor is not in the hospital only. Because sometimes you're part of the community. Let's say if you go to your nearest masjid or your surau, this is part of the things that they expect to know. They expect you to share.
Look, the next question they ask us to ask is working in the ER really anything like we see in Grey's Anatomy? First of all, nobody look as good as any of the doctors in Grey's Anatomy.
Okay.
There's no Max Teamy, there's no Mac Dreamy. How I wish. Okay, maybe cut that off. But but really.
And then we have no time for. Not saying
the drama
and the romance and there's crying in the hallways and looking for your intern in the stairwell. We have no time for that. If you're missing, I will page you.
MIA.
Where are you?
Yes,
No, I don't have time. Are you okay? Is it McDreamy is doing something to you? I don't. We don't do that. Because it's more dramatized and not only Grey's Anatomy.
And okay, I'm a big fan. Okay, say whatever you want. Right? Grey's Anatomy is a good kind of an indulgent sort of soap. They don't really have an emergency physician until much later. And even then, it was like a trauma surgeon who went to like a war zone or something, and he ran the A&E. And I was like, I don't know. Because I'm not convinced.
Okay, my son. Okay, just to share a bit. My son forced me to watch. There's one Korean show, Trauma on Call or something. Heroes on Call or Trauma on Call, something like that.
Yes.
Dr. Baik
but
or something.
He's
a trauma surgeon and runs the emergency department. So
that's not how it
is. That's a difference because people are thinking
that's what we do. We come in with our hair all nicely set,
and then I go on helicopters, the mountains. We don't do that.
And wind blowing in our faces.
And then
we come in
very nice suits every day. This is only for today. I'm wearing this. Most of the time I'm wearing.
I know.
It's something comfortable that you have to work in.
So in short.
And the thing with TV or dramas, that's one thing. But what I feel that they can do better, maybe the locals, is the information, the medical information.
Okay.
Because sometimes I do get scolded by relatives, saying that a patient with a straight line, asystole in the monitor, asystole, we need to do CPR.
Okay.
But they saw it in TV or movie that when there is a straight line, you give shock. So they were asking, doctor,
kenapa you tak shock?
Kenapa you tak bagi my mother? I cakap, no. So I have to give lectures on that. Then, this is the thing. If the TV and dramas can help to disseminate the correct information, it will be easier.
Have you seen The Pit in HBO Max? That's accurate. That's accurate. Although hour by hour, minute by minute, I would say that's pretty accurate.
And then there is a disaster.
Yes, there's a disaster
and everything.
And the overcrowding bit. I haven't laughed like this in a while. There's really nothing
You
funny
need to come
happening in
here
the
often.
A&E. There was an interview that went viral a couple of months ago, or was it last year? They interviewed a pediatrician by chance, and she was saying how her salary is like 60k to 70k, and internet went wild.
Not only that,
Are you making 60k to 70k?
my son was asking, why are you not giving me this and that because you're earning that? I said that's a different thing. For emergency physicians, and for emergency physicians, we are actually staffs of the hospital. We are paid salary, and with some patients, and you see, so it's not as much. It is not as good. No. Macam mana nak cakap?
It's comfortable.
Not, okay. It's comfortable, but we are not rich.
We are rich with
experience,
happiness and experience.
But not with money. Because the other specialties they are earning because they are doing procedures, they are doing operations. But for us, we are staffs of the hospital.
That's right.
So if it's a monetary wise, I would say we are not. But experience wise, health wise, I'm happy with myself.
Rich is such a subjective thing.
So
it's okay. We're alright. I'm happy. Okay. So anything else? Any other insights that you would like to share, Dr. Shahrul, before we kind of conclude our KoPiJom session today?
For me, I feel that this is I'm always interested in sharing of information, medical information, especially with the public, and having a platform to share. To me, I always appreciate this because sometimes people don't understand what's going on behind the scenes of emergency department. They feel that why I have to wait long because this is emergency. So why I'm waiting long? Because we have other unstable patients. So these are the things that we have to explain.
I'm going to quote Dr. Rizwan. Ni adalah jabatan kecemasan. Ni bukan jabatan kecepatan. And I was like, okay, alright, I got you.
Cemas doesn't mean cepat. So it's a good sharing platform so that people would understand what goes on. Who are we in the emergency department? What is our role within the department, within the hospital, and within the KPJ itself? And then it's a good outlet. At least for today, I got some chit chat.
Emergency doctors tu macam apa? Wira tidak didendam. The unsung heroes.
The unsung heroes.
It's a bit of a self-proclaimed thing to call ourselves heroes, but
since no one calls it, so let's call it.
But definitely unsung, alright? Okay, definitely tidak didendam. Wira, okay lah, you nak ke tak nak, tapi definitely tidak didendam.
Tidak didendam tu is correct.
But so it's good now that we have more avenues. You've got a couple of TV invites. I've got a couple of TV invites. People want to know, and first aid is part of emergency medicine. Exactly. First aid is important. We talked about CPR and why it's important for us to learn CPR, because every minute that you don't do CPR, the percentage of survival in our patients reduced by 10%. That's after every 10 minutes you don't do, 100% gone.
And then some people would say, hey, we're waiting for the ambulance.
No, please.
So you lose, because
a chunk of time.
Unlikely ambulance will come in by 10 minutes. And you know that by 10 minutes,
it's gone.
You have lost a lot. So, and always we say that who's the best first aider or who's the best first responder? Your surrounding people, your
the bystanders.
That's why you have your first aid, your mini pharmacy at your home.
I'm proud of that.
Because the neighbours are the one that helps you.
The bystanders, the people around you.
So, if we train as much people as we can, if we share knowledge as much as we can, actually we're helping. Just in case anything happens to us, someone might be able to help.
It's a bit of a selfish pursuit there, but yes.
So we train as much people.
I think the knowledge of having information about how to do first aid, how to do the story you shared with us about the bleeding child, for instance. If there was a bit of awareness, there is a bit of education that's going around. I do feel like it helps us.
It helps a lot
in A&E when we resuscitate patients. To improve the outcome, because again, the tipping point has not been reached if the initial resuscitation has been done by the bystanders. So it's good that we're having these avenues to share our insights. Any last words before we leave?
For me, I would say thank you very much for this opportunity. So for people to hear on what is our take,
if they've stayed this long,
through
our chatter.
this is short sendiri.
Okay.
But I would say that as long as the public is informed, it helps, and every little bit helps. Especially in emergency cases, what you're going to do. So I do hope that this platform and this sharing can be continued later on. Okay.
Most people would know the A&E as accident and emergency, but for us, emergency physician, it carries a vastly different meaning, right, Shahrul?
Yeah, most of the days it can be anything and everything.
So thank you so much. This has been Real Talk from the A&E. Stories that stay with us.